Thank you, Dr. Musa. Thank you, Dr. Ahmed. Thank you, Dr. Abdullah Shahab, for the introductions and for the very interesting conference in Dubai. My topic today about complete revascularizations in 2025. So I will start my presentation with a case. This is just, doesn't work. This is a 41-year-old male patient. He presented with inferior ST elevations MI, stable vital signs, cath showed. This is severe RCA lesions. In addition to that, there is moderate to severe LAD lesion. What to do with these patients? Of course, you go for culprit lesion, you do it, and for non-culprit lesions, we will go for evidence-based medicine. So we have, the slide goes automatically, we have a problem with that.
Just press one time, yes.
You have, لا. It's يعني لحاله بروح لحظة. شايف؟ We have a problem with.
Can you solve the problem, please, my team?
But who's playing? You play?
لا دعس عليه لحاله. طيب. Okay. So we have three important questions. Is it beneficial to open up non-culprit lesion? Question number one. Question number two, how to select the non-culprit lesion? Of course, if it is beneficial to open up non-culprit lesion. Question number three, what is the optimal timing for non-culprit revascularization? Now, about 30 to 50% of patients with STEMI present with multivessel disease. Patients who present with STEMI and multivessel disease have higher mortality rate than those with single vessel disease. And you should know that not only worse prognosis, not only with numbers of vessels, it's worse with, if involved with CTO, if involved with left main disease. So, let us look at the largest randomized clinical trials on complete revascularizations in patients with STEMI and multivessel disease. This is complete trial. And if you look at the results of complete trial, there was a significant reduction in the first co-primary endpoint, which include cardiovascular death or a new myocardial infarction. In the patients with treated in complete revascularization versus culprit only. Similarly, there was a significant reduction in the second co-primary endpoint, including cardiovascular death, new myocardial infarction, and ischemia-driven revascularization. So, what about patients over 75 years old? Is there any benefit from full revascularization? This question was answered by FIRE trial, which specifically studied patients over 75 years old. The FIRE trial, which was published in New England Journal of Medicine 2023, involved patients with age more than 75-year-old with MI and multivessel disease. And the result, the FFR guided or physiology guided complete revascularization significantly improved outcome comparing with non-culprit. And the FIRE trial, this was lasted, the median follow-up was 1 year, and newly published the study was extended to 3 years, and the reduction in the primary endpoint remained consistent. This is a meta-analysis of 8 randomized clinical trials involving approximately 6,700 patients with the STEMI and multivessel disease, and comparing Complete and Culprit, and starting with the MACE, most trials showed significant reduction in MACE incidence in a patients treated with complete revascularization compared with Culprit only. What's about cardiovascular mortality? The same. There is significant reduction in Complete versus Culprit. Regarding reinfarction, complete revascularization significantly reduced the incidence of reinfarction. And similarly, similar reduction was seen in cardiovascular hospitalization as well as urgent revascularization. What about the complications? There were no significant differences in post-procedural stroke, bleeding, or contrast-induced nephropathy between the complete revascularization and Culprit lesion PCI. What about both ACC, AHA guidelines and ESC guidelines give a class 1 recommendation for complete revascularization in hemodynamically stable patients. Those patients is usually blood pressure is normal, not shock patients. Question number 2. How to select the non-Culprit lesion? Either angiographic guided or FFR guided. So, this trial compared FFR guided PCI with angiography guided PCI in STEMI patients. This is the flower trial, showed no significant difference in a primary endpoint between angiography guided PCI and FFR guided PCI. So this result is negative. In contrast to the FIRE trial, the FAME trial showed a significant reduction in events with FFR guided strategy compared to the angiography guided strategy. So, what about the guidelines? This is the guidelines says it is recommended that PCI of non-Culprit based on angiographic severity. What about the FFR or physiological function is considered as a class 3? Question number 3. What is the optimal timing for non-Culprit revascularization? This is a multi-stars trial. Immediate multivessel PCI in stable ST elevations MI patient is not inferior, but also superior to staged PCI in terms of reducing MACE at 1 year. So there is a significant reduction in immediate versus staged. And this is the BioVasc trial. This is also the same results. It is not only inferior, it is superior in immediate versus staged. In the complete trial, there was no difference in outcomes between immediate and stage PCI of non-Culprit lesions. So this is a meta-analysis. In this meta-analysis of 8 randomized clinical trials involving around 3,500 patients, mean follow-up was around 1.5 years. There was no significant differences in the primary endpoint between immediate and stage revascularization. But if you look, it is maybe a little bit in favor of immediate. But if you look at the confidence interval, it is not really significant. complete immediate revascularization is non-inferior or better than stage complete revascularization. More trials on the optimal timing of complete revascularization are warranted. I will go back to my case. This is Young, who presented with inferior MI. We have 2 lesions, LAD. I fixed the RCA, and I did it at the same time. Why? It took me less than 10 minutes to fix the RCA. Another case, this is case number 2, 55-year-old male patient with acute inferior MI and stable vital signs. And if you look at, this is total RCA or subtotal RCA, and we have here's moderate lesion in LAD, and we moderate to severe lesion, and we have severe lesion circumflex. What to do? Actually, this patient, he developed non-reflow phenomena. It took a lot of adenosine. It's more than 12 milligram intracoronary time. So in this case, I decided to postpone the non-culprit lesion. So actually, I did it after 1 week. I have just 2 cases. You can with or
Give him 2 minutes, please. How?
okay. It doesn't work. Okay, this is, I want to show you the cardiogenic shock patient. Just where is, this is a 55-year-old female patient. She is hypertensive diabetic. She presented with low blood pressure, and this is the circumflex subtotal. And we have significant LAD lesion. In this case, I decided just to fix the circumflex, and after 1 week, I did the LAD. So in the guidelines, it's contraindication to do all vessels at the same time in shock patients. This is considered in ACC, AHA guidelines and European guidelines. And thank you.